Good afternoon, everybody. On behalf of the Department of Pediatrics, Unit 3, the Division of Pediatric Pulmonology will be presenting today's clinical combined round. And I request Dr. Kanaram to come forward and carry the discussion.
Okay, good afternoon all. So today we will discuss the one challenging case that was challenging the diagnosis, and finally we diagnosed the one unusual diagnosis by some innovative technique. So I request the Dr. Mudit will present the case and Dr. Akshita will present the discussion part. So may I request Dr. Mudit to start the proceedings.
So, good afternoon, everyone. So, we'll be discussing the index cases of Master A, who is a 7-year-old boy who a resident of Bihar. He presented with the chief complaints of fever for the past 1 year, cough for the past 1 year, and blood-stained sputum for the past 1 year. In the history of presenting illness, the child initially had fever. So the child initially presented in August 2022 with fever, which was low-grade fever, 100 to 101 degree Fahrenheit, intermittent in nature, associated with chills, and relieved on antipyretic medications. It was not associated with any night sweats. And in the last 5 days before the child presented to us, the fever had increased in intensity to a high-grade fever of maximum 103 degree Fahrenheit. Along with the onset of fever, the child also developed an insidious onset of cough, which was dry type, intermittent in nature. There was no postural or diurnal variation in the cough, and there were no episodes of post-tussive vomiting. He also had several episodes of blood and sputum, which was fresh blood associated with bouts of cough. Initially, the child was only having 2 to 4 episodes every month, which was small in volume, 2 to 4 teaspoons in quantity with every episode. However, there was progressive increase in the frequency of these hemopsis episodes to a maximum of 2 to 4 episodes per week. 2 weeks prior to presentation to AIIMS, he had one episode of large volume hemopsis, approximately 100 ml. He had multiple previous hospital visits before presenting to us and was given anti-tubercular therapy prior to presenting to AIIMS. In the negative history, there was no associated history of difficulty in breathing or weight loss. There was no history of bleeding from any other side to suggest a bleeding diathesis. There was no history of nasal discharge, redness of eyes, joint pain or joint swelling, or any headache and facial pain to suggest any paranasal sinus involvement. There were no gastrointestinal complaints or any urinary complaints. No history of any foreign body aspiration, and no history of contact with a person with tuberculosis. The child also did not have any history of travel. The birth history was normal. He was a single term normal vaginal delivery, and perinatal course was uneventful. He was a fourth born child of a non consanguineous married couple. There was no history of tuberculosis or any other major illness in the family. He was a developmentally normal child, currently studying in second class at the time of presentation, and had been immunized till 5 years according to the national immunization schedule. In the socio-economic history, the father was a fruit vendor, and by modified Kuppusamy scale, the family was at a lower class. They lived in a pakka house, and overcrowding was present in their household. There was no history of passive smoking by any of the family members. No history of any damp walls or mold in the house, any factories near their house, or any exposure to pets or pigeons. In the dietary history, the child had a deficit of 380 kilocalories, and protein intake was adequate. So before he had presented to us, the child had been started on first-line anti-tubercular therapy based on clinical and radiological findings. There was no microbiological evidence for the same, and he had already received first-line ADT 2 months of intensive therapy and 4 months of continuation phase before he had presented to us. He had also received courses of oral and IV antibiotics, although the details of the same were unknown. But there was no improvement in symptoms with these therapies. Moreover, there was progression in these symptoms. So coming to the examination, in the general physical examination, his vitals were within normal limits. At the time of examination, he was afebrile. In the general physical examination, the pallor was present. Otherwise, the child did not have any clubbing, cyanosis, pedal edema, or lymphadenopathy. Anthropometric parameters, as we can see, are within the normal limits. So moving on to the respiratory system examination. On examination of the upper airway, the nasal cavity was normal. There were no polyps, no ulcer, nor no saddle nose deformity. The oral cavity was normal. There were no dental caries, and oral hygiene was adequate. Tonsils were normal, and there was no sinus tenderness. On inspection of the chest, the trachea was central and the chest expansion was equal bilaterally. The apical impulse was seen in the fifth intercostal space, lateral to the midclavicular line, and there were no scars, sinuses, or dilated veins present. On palpation, the inspection findings were confirmed. However, we noticed that vocal phreatitis was increased in the right infraclavicular and the mammary areas. On percussion, there was a dull note present in the same areas. Liver dullness was noted in the fifth intercostal space on the right side. On auscultation, the air entry was reduced again in the right infraclavicular and mammary areas. And in these same areas, we had an increased vocal resonance and bronchial breath sounds. And inspiratory coarse crepitations could also be heard in the right infraclavicular and the mammary areas. In the other systemic examination, the cardiovascular system was within normal limits. Per-abdomen examination did not reveal any hepatosplenomegaly or free fluid. Central nervous system examination was also within normal limits. The child did not have any focal deficits or any meningeal or cerebellar signs. To summarize the case, this is a 7-year-old boy symptomatic for the past 1 year with fever, cough, and recurrent hemoptysis with progression of symptoms. He had previously received anti-tubercular therapy for 6 months, however, without any response. There is no history of contact with tuberculosis, and examination findings were suggestive of consolidation in the right upper lobe. So, with this history and examination, the following possibilities were kept. The first possibility was of an infection. So, since he had fever, cough, and hemoptysis, tuberculosis was the first possibility. However, since he had already received first-line ATT, we were suspecting drug-resistant tuberculosis. Points against were that the child did not have any weight loss and was relatively well preserved. Another infective possibility was of a lung abscess because of fever, hemoptysis, and no response to ATT and localized examination findings. However, the history was prolonged. It was a 1-year-long history. Fever was only low to moderate grade, and the child was not sick looking. The other possibility was of unusual infections which were low in virulence, such as a hydatid cyst, a fungal infection. The points in favor were low-grade fever, cough, hemoptysis lasting for a long duration. However, the child was premorbidly normal. He had not been had any exposure to animals or any immunosuppressive drugs, and there was no other contributory history to suggest that the child would have an unusual infection. Vasculitis was another possibility. A small vessel vasculitis such as polyangiitis with granulomatosis or microscopic polyangiitis. The points in favor were persistent fever and hemoptysis. The points against were the child's age was not matching with this diagnosis. There were no extrapulmonary manifestations and there was no history of atopy. Other possibilities kept lower down were tumors such as an inflammatory myofibroblastic tumor or a carcinoid tumor in view of the prolonged history and non-response to treatment. But there was no weight loss and there was no breathing difficulty. An AV malformation was another possibility, but the child had been well since 7 years of age, so a congenital AV malformation presenting this late would be unlikely. The same was true for other congenital malformations such as foregut duplications or sequestrations. The last possibility we kept were of forgotten foreign body aspiration, but the child did not have any such history, and there was persistent fever which was against a foreign body. So the initial investigations of the child revealed only, as we can see here, he just has moderate anemia and leukocytosis with neutrophilic predominance. Platelet counts were within the normal limits. His liver function and renal function tests were within normal limits. His CRP, he had an elevated CRP at 78.8 milligram per liter. Procalcitonin was negative. Gastric aspirate was sent for a gene expert for tuberculosis, but was negative. And the HIV antibodies were non-reactive. Further, we will discuss the radiology, for which I'll call upon Dr. Krishna.
So this boy had serial radiographs starting from August 2022. In the August 2022 X-ray, we see that the bilateral lung fields are clear, the cardiac silhouette is normal, bilateral hilar shadows are clear, and the CP angles are sharp. Basically, this was within normal limits. In the radiograph of December 2022, we can see ground glass opacities in developing the right upper zone, although there is no definite area of consolidation. But within 6 to 7 months, this has progressed to a consolidation with a convex border. So this is called like a mass-like consolidation. At this point, we also start to see some lucencies that are developing within. And this has progressed between May and July 2023. So this was the picture on serial radiographs. The child also had an outside CT scan done during December 2022, in which also we can see patchy areas of consolidation or atelectasis with surrounding ground glass opacities in the apical segment of the right upper lobe. There are no areas of cavitation, consolidation, nodules to suggest tuberculosis at this point, and there is no pleural effusion either. In the mediastinum, we do see enlarged hypoenhancing lymph nodes in the subcarinal and the right paratracheal areas. So these are necrotic lymph nodes. In-house, we had done a CT angio for the hemoptysis in June of 2023. In this, we could see that the has progressed to a mass-like consolidation with internal cavitation that has developed and hypoattenuating areas. There are also surrounding nodules and ground glass opacities. All of this is in the apical segment of the right upper lobe. It is involving the mediastinal pleura, the brachiocephalic vein, the azygous vein, and reaching up to the right hilum. The lymph nodes are also persistent, as we can see here. And in the angiography phase, in the mediastinal window, we can see that there is increased vascularity in the periphery of this consolidation, along with enlarged right intercostal bronchial trunk, giving the intercostal supply as well as supply from the bronchial artery, and another separate right bronchial artery, which is also supplying the area of consolidation. So these were the abnormal increased supply to this area of consolidation. So to summarize, we have a 7-year-old boy with fever, cough, hemoptysis not responding to antitubercular therapy. Serial radiograph showed us ground glass airspace opacities in the right upper zone progressing to mass-like consolidation. And the angiogram again showed mass-like consolidation, which has developed internal cavitation and ground glass opacities with hypertrophied and tortuous bronchial artery branches supplying the wall. So our possibilities would include primarily an infection because of the long history with fever. But this will be an atypical infection like a fungal or a tuberculosis, but it was not responding to ATT. Neoplasm would be unlikely in this scenario. From a therapeutic point of view, a DSA was done with the plan of embolizing the abnormal tortuous bronchial arteries. So in the DSA run, we can see this abnormal right intercostal bronchial trunk. So this is the intercostal part, and this is the right bronchial part, giving abnormal blush in the parenchyma. And this is the separate right bronchial artery, which is also showing this abnormal blush. So after embolizing this with the 300 to 500 micron polyvinyl alcohol particles, predominantly the blush was obliterated with some residual vascularity still from the intercostal artery part.
So with the DSA, we had we were able to control the hemopsis, but the diagnosis was still a challenge. And the main challenge was that we needed a microbiological diagnosis. So the plan was to obtain an appropriate lower respiratory tract specimen. So our plan was to go with a relatively non-invasive test first and proceed with bronchoscopy and bronchoalveolar lavage. If this proved to be inconclusive, we would further proceed with a lung biopsy or an FNAC. So bronchoscopy was done for this child, and here we can see as we are going into the right lobe, we are proceeding in the right upper lobe, we can see that secretions, mucopurulent secretions are present in the right upper lobe. And as we proceed further, we can see that so we see secretions that are present in the right upper lobe, and as we proceed further, there is irregular thickening of the mucosa in the apical segment of the right upper lobe. From this segment, we took a BAL specimen, which is being shown right now. Otherwise, the airway anatomy was normal. So the BAL reports revealed the following results. Gene expert, Gram stain and other special stains were negative. Bacterial culture and sensitivity was sterile. KOH stain for fungus was negative. BAL galactomannan was positive at 1.9. However, since the serum galactomannan was negative and fungal culture and sensitivity did not reveal any fungal organism, we did not act on this. The cytopathology was suggestive of few polymorphs, lymphocytes, and alveolar macrophages. So the BAL was, in a sense, inconclusive. So the next step was to obtain a biopsy or an FNAC sample from the lesion. However, there were certain challenges in this procedure. The options available to us were either a percutaneous transthoracic lung biopsy, which would be guided by ultrasound or CT. However, since the lesion was surrounded by vessels, there was a high risk of pulmonary hemorrhage. And because of the vessels surrounding the mass lesion, there was no appropriate window available for transthoracic procedures. Bronchoscopic biopsy was another possibility, but there were no endobronchial lesions. The airway anatomy was essentially normal. An open lung biopsy would give us a larger tissue sample, which would be adequate, but there were associated surgical risks. Radial endobronchial ultrasound guided biopsy also had a similar risk of bleed because the region was vascular in nature. So the other option was to obtain an endobronchial ultrasound guided transbronchial needle aspiration of from the lung lesion. So to discuss the EBIS TBNA that was done for this child, I would like to call upon my colleagues from adult pulmonology.
Thank you. So, so EBUS TBNA, for those who are not aware, is basically an ultrasound put on a bronchoscope tip. You can go inside the airway, get an imaging through the airway of the surrounding structures, and in real time you can do a needle aspiration. So we tipped this child up for an EBUS screening procedure, and what we essentially saw here was that you see the needle coming from here, and we actually had a paratracheal lymph node, and then you see the lung mass located beyond the lesion. So we basically went through the bronchoscopic route, and this was done in general anesthesia. A laryngeal mask airway was the airway conduit. And using the endobronchial ultrasound scope, we could localize the paratracheal node as well as the mass. So we aspirated from the node, and then we did a puncture through the node into the mass, and we did an aspiration from the right upper lobe lung mass. So basically, it was a 22 gauge EBUS needle. Using this, we can obtain samples which are essentially aspirates, and you can also, process them as histopathological samples if you put them in formalin, and you get the microbiology as well as the tissue specimens. The procedure was uneventful.
Thank you, sir. So initial tests on the lung aspirate sample, it was negative for acid-fast bacilli. Gene expert from both the lung mass aspirate and the lymph nodal aspirate was negative, and for fungal elements also the aspirate and lung mass was negative. However, as sir said, the sample was sent for histopathology by making a cell block of the sample, and the histopathology revealed answers to the child's diagnosis. To discuss the histopathology, I would like to call my colleagues from pathology.
A very good afternoon, everyone. We made cell block of the EBUS TBNA sample that was received. And this is the HE stain slide. And there was dense acute inflammatory infiltrate composed predominantly of polymers. And there was necrosis along with presence of numerous filamentous bacteria. And we performed the second picture is that of gram stain. We performed the gram stain, and it revealed that these bacilli were gram positive filamentous. Thereafter, we also did the SM stain. This is a silver methenamine stain. And these filamentous bacilli were highlighted on the silver methenamine staining. And we came to a conclusion that it was actinomyces.
Thank you, ma'am. So with the histopathology, we were able to reach a final diagnosis of pulmonary actinomycosis. So to go ahead with the treatment, we started the child on oral amoxicillin. So penicillin derivatives are the first line of therapy for pulmonary actinomycosis. But as we can see, the dose is much higher than the usual dose used for bacterial infection. So we started on 100 milligram per kg per day, and the dose had to be given for a prolonged duration of 6 to 8 months to ensure that the infection would clear. Presently, the child, after starting therapy, is doing well. He does not have any fever or hemoptysis, has gained significant weight, and on radiology also we can see that at the diagnosis and after 4 weeks and 4 months of treatment, there is significant resolution of the lesion on the chest X-ray as well. We plan to give the therapy for a total of 6 to 8 months and keep the child in clinical follow-up. For the discussion, I would like to call Dr. Akshita.
So, good afternoon, all. So, having arrived at this rare diagnosis with a lot of help from our colleagues from other department, we'll briefly review EBUS TBNA in children and pulmonary actinomycosis. So, EBUS TBNA, as already highlighted by Dr. Karan, involves the use of a dedicated ultrasound-equipped bronchoscope, which enables real-time sampling from mediastinal and hilar nodes. So, the scope is basically passed through the airway, and we identify the lymph node, and through the scope itself, through the working channel, the biopsy is done. So, but the major limitations for its use in children include the large diameter of the EBUS scope. The smallest available scope right now is 6.3 millimeters, which is also much larger than the pediatric bronchoscopes that we use. So this difficulty can be bypassed in smaller children by doing it via the esophageal route. That is a trans-esophageal bronchoscopic ultrasound guided fine needle aspiration. So this EBUS TBNA and the esophageal route combined both have a pooled sampling adequacy of 98% in children and a combined diagnostic yield of 61%, 63% being the diagnostic yield in adults. So it approaches the adult figures as far as the diagnostic yield is concerned. And it's been found to be useful, safe, and feasible in the pediatric population. The most common sites for performing EBUS guided aspiration in children are the lower right paratracheal and subcarinal lymph nodes. What was novel in this case is that other than sampling the lymph node, it's also sampled the parenchymal lesion. And that was the novelty here. In adults, it's been routinely used for diagnosing centrally located lung tumors, but there are no reports of sampling lung lesions in children. So this was the first reported case of sampling lung lesion using the EBUS scope. Regarding pulmonary actinomycosis, it's caused by gram-positive anaerobic prokaryotic bacteria which belong to the family Actinomycetaceae. And these are difficult to diagnose and are often, the diagnosis is often delayed or there's a misdiagnosis, as it happened in our case also. So the type of actinomycosis in children, while earlier we used to have very florid manifestations with draining sinuses and often requiring surgery, thankfully now with the rampant use of antibiotics, its incidence has come down. The cervicofacial form still continues to be the most commonly identified form with 50 to 60% prevalence. The pulmonary being a close second, the pulmonary being a distant second at 15%. The other forms are abdominopelvic, CNS, and cutaneous, which are now rare. Pulmonary actinomycosis per se is a rare entity in children and has a bimodal peak at 11 to 20 years. The peak in childhood being at 11 to 20 years and the adult being between 4th to 5th decade. The mean age of diagnosis in children is 10 years with a male predominance. Risk factors for acquisition of pulmonary actinomycosis are aspiration of the oropharyngeal secretions. So the risk factors that have been identified are poor oral hygiene, dental caries, facial trauma, respiratory disorders like emphysema, chronic bronchitis, and bronchiectasis. These are also reported in neurologically impaired children and in immunocompromised hosts. In adults, the underlying conditions being diabetes, mellitus, and alcoholism. Clinical features of pulmonary actinomycosis are non-specific, but the most common clinical feature that is reported is a chest. They're mostly present with a chest wall mass. The patients often present with cough, pain in the back, chest, or shoulders, weight loss, fever, and draining sinuses. So as we can see, it often mimics tuberculosis. And hemoptysis has also been reported in 9% of the children. Initial investigation, we may find mild leukocytosis, predominantly polymorphonuclear forms with raised ESR and CRP. Radiology-wise, chest X-rays are non-specific. In adults, peripheral and lower lobe involvement has been reported. CT scans may show patchy airspace consolidation, multifocal nodular appearance, cavitatory lesions, pleural effusion, and hilar or mediastinal lymphadenopathy. Pulmonary infiltrates and consolidation with air bronchograms, often referred to as the air sign, may be suggestive of a thoracic form of actinomycosis. So as we can see that it often mimics TB, malignancy, and lung abscess, which leads to delayed and missed diagnosis. As far as the role of bronchoscopy is concerned, bronchoscopy is usually not diagnostic because a simple culture from the bowel is usually inadequate for diagnosis. It needs anaerobic collection with a protected bronchial brush. That too, if there is an endobronchial invasion of the lesion. However, bronchoscopy has a role because it can exclude airway tumors and endobronchial TB. And endobronchial actinomycosis may manifest as irregular mucosal thickening, which was seen in the bronchoscopy in our case, or as an exophytic mass with partial occlusion of the bronchi. Lung biopsy is usually required for histological and microbiological confirmation. And the approaches we've already discussed in the previous slides, but the percutaneous lung biopsy carries that can be done with an ultrasound or CT guidance. But that carries the risk of that also carries some risk of pneumothorax and bleed. And here in our case, because of the surrounding vessels, that could not be performed. A blind thoracotomy is of course less preferred. Using the endobronchial route, we can do a lung biopsy if an endobronchial lesion is identified, and a radial guided EBIS can also be done for peripherally located lesions, but there is a risk of bleed. In our case, our adult colleagues performed endobronchial USG guided aspiration for diagnosis. Microbiology wise, they are difficult to culture, mostly because there has to be a high index of suspicion, and then they would require adequate culturing technique. Also, previous antibiotic therapy would interfere with the culture, and they are often there is often a bacterial overgrowth because they often occur as mixed infections. So, culture can be done on chocolate agar medium, brain heart infusion broth, brucella blood agar with hemin and vitamin K1, and the colonies of actinomyces, they appear as molar tooth or breadcrumb colonies, as we can see here. Microscopy wise, they are filamentous structures, and sulfur granules are the pathological hallmark of this disease. And these are the staining techniques that can be used for actinomyces. They show colored fungal hyphae. Here, this is the Gomori methamine stain. So while the diagnosis is difficult, for treatment we have penicillin, which is the drug of choice. However, antibiotic is required for prolonged durations, and higher doses are required. So therefore, relapses are common because most of the patients would not be completing these regimes. The response to treatment can be monitored radiologically, and the response is first visible in 4 weeks, as we could see even in our case that within 4 weeks the lesions had started subsiding. Surgery is required in case of complications with abscess, empyema, discharging fistulas and sinuses, and in cases of life-threatening hemoptysis. The disease carries excellent prognosis with low mortality if it's detected early, and it's of course less favorable if there's disseminated disease. So the take-home message from our side is that all persistent pneumonia is not TB. Lung biopsy may be required in cases where conventional imaging fails to diagnose the underlying etiology. EBIS TBNA is a safe procedure generally performed for mediastinal lymph node sampling, and the use may be extended to sample lung lesions like it was done in our case. Pulmonary actinomycosis is a rare entity in the pediatric age group, and a high index of suspicion is required. The diagnosis is difficult, but the condition is treatable with a good prognosis. And this case was also published. Thank you.
Thank you all. So here the first challenge was to control the hemoptysis. So with the help of the radiology team, we perform and child underwent the bronchial artery embolization and hemoptysis control. Second was the diagnosis. As we discussed, very difficult to diagnose. So this is the first case in the pediatrics that this mass was diagnosed by this EBIS tool. With these comments, case is open for the comments and questions. So may I request Kabar sir to Kabar sir join us back as the consultant. So case was managed under guidance of the Kabar sir. So I request some comments from Kabar sir.
EBIS ultrasound is evolving, and I got trained under adult pulmonary medicine and started in our department. But taking a sample for the lung, it was first time with their support. And it is evolving, its indications are evolving, and probably it may replace almost 50% of the surgical intervention by doing these diagnostic as well as some therapeutic. This is a bronchoscope, usual bronchoscope, and there is a ultrasound on the tip of the bronchoscope. Larger because we use generally 2.8 or 3.8 millimeter, so it is almost double the size. Because you have to have ultrasound, one the passage for passing a needle, and then your fibers, or taking a camera over there. So they are trying, probably now we'll have a 5.8 millimeter.
So just a quick question. How is it radial EBUS versus this route was selected?
So basically, radial endobronchial ultrasound is basically a lung biopsy. Through a bronchoscope, you put a very small, thin 360-degree ultrasound scope, basically. But the sampling during that is blind. And essentially, you are taking out a piece of lung through the airway. So the risk of bleed is greater. In this case, we are just going with a needle through the peribronchial approach. So I think it's less complicated. And you get to the center of a lesion with greater consistency.
Actually,
we
the
didn't suspect
percutaneous
that-
approach was not used because the peripheral aspect of the lung was very much vascularized as compared to the medial aspect from which you have directed the needles.
Even here, we didn't suspect the ectomasis before the biopsy. So even though they have reports in the literature also, many times the cases are diagnosed after the lobectomy also. It didn't, so this is very difficult to diagnose the actinomycosis. Yes, sir. This is a slow growing bacteria. So they need to, at least we have reviewed the literature also. Even the child is after 4 months, the light X-ray is the much better. The literature is 8 to 12 months is a recommended treatment.
And in actinomycotic infections of the skin, which are mostly exogenous,
Yes, sir.
also we give treatment for many months, 12 to 18 months.
Thank you. Then with this comments, we close this case. Thank you all.